On March 18th, 2021, Kent Taylor, the founder and CEO of the restaurant chain Texas Roadhouse, took his own life. According to his family, the cause of this event was a rather common physical condition, occurring in, by some estimates, 1 in 10 adults, although the form of the condition that Mr. Taylor acquired is more severe and more rare, but still occurs in roughly 1% of the population. That condition is tinnitus. Although there is some debate still ongoing about the issue, there is a good amount of evidence connecting this common condition, tinnitus, to an increased risk of suicide. A study published in May 2nd in the Journal of the American Medical Association found a link between tinnitus and suicidal tendencies, specifically in a rather large study in Sweden. 9% of the women and 5.5% of the men with severe tinnitus tried to commit suicide, compared to 3.4% of the entire sample population. Despite the connection between tinnitus and the risk of suicide, as well as the connection between tinnitus and other mental health conditions, it would be almost an exaggeration to say tinnitus is under the mental health radar. It is off or not even on the mental health radar. And in this talk, I hope to put that back on the mental health radar. So in this presentation, you'll find out what tinnitus is and why mental health professionals ought to be concerned with tinnitus. You'll find out which therapeutic interventions are successful in working with tinnitus. As well, you'll get some specific direction in how to work with a tinnitus client. So I am Peter Vernizzi. I am a licensed therapist in Arizona. In terms of some of the interventions I'll be talking about in this talk, I am a qualified teacher of mindfulness-based stress reduction through the University of California, San Diego Center for Mindfulness. I'm also on the national provider list for cognitive processing therapy, as well as a meditation teacher trained in the Shambhala tradition. And I also am tinnitus challenged myself, having developed the condition about 5 years ago. So first, some basic information about the condition. Tinnitus can be defined as the conscious perception of unwanted subjective auditory sensations in the absence of a related external stimulus. Although it's called ringing in the ears, the nature of the sound, in fact, varies widely in terms of loudness, pitch, location, and the number and types of sounds. My own particular tinnitus is somewhere between pipes running through a toilet drain, in the morning hours, to about a cascade of crickets in the evening. So it is a prevalent condition, impacting, at some estimates, 1 in 8 adults. And its prevalence is expected to continue to rise due to a number of risk factors, such as increased life expectancy and recreational noise exposure. As for the pronunciation, there are 2 pronunciations you will hear. Neither is the preferred one, tinnitus or tinnitus. Either is correct. Tinnitus itself is considered a symptom and not itself a disease. A symptom of hearing loss is one of the factors that is related to tinnitus. Stress is another factor related to tinnitus. Another risk factor, exposure to loud noises, certain medications, ear diseases, an eighth nerve tumor, head injury, increasing age, can all be related as factors connecting to tinnitus, although the first 2 are far and away the most common causal factors that are related to tinnitus. And in addition, both the COVID vaccine and the condition itself are suspected of causing tinnitus. And in fact, with Mr. Taylor, it was he acquired COVID and then acquired the tinnitus. That was the situation in his own case. Although this connection has not been verified in any standard justified scientific manner at this point, it is suspected, especially largely suspected and talked about within the tinnitus community. So one of the first things we need to do is distinguish between two types of tinnitus, bothersome and non-bothersome. The definitions, the terminology pretty much describe what goes on in these conditions. Bothersome tinnitus is a sort of tinnitus that causes anxiety and distress. It affects the quality of life, and it's usually enough of a concern to cause the person dealing with it to look out help. A number of people have non-bothersome tinnitus. It's simply, they can have essentially exactly the same noise, the same sound, but they don't get anxiety or stress, and it doesn't affect the quality of life, and they don't seek help. So it's just a matter of which sort of, and why tinnitus bothers some folks and not others is a matter that's not exactly clear, although there is a number of speculations. So let's go over to bothersome tinnitus, because that's really the only type that's ever going to be an issue for a mental health therapist. So roughly only about 10 to 20% of those with tinnitus develop bothersome tinnitus, which works out to be between 1 to 3% of the general population. That's obviously where Mr. Taylor fell into. Many people are initially bothered by tinnitus, but after a few months, their annoyance lessens. A lot of the studies we're going to be looking at are done overseas. There's just a lot more research done in Europe and England than compared to the United States. But one results of a national study in England found that 2.8% of the total population described their tinnitus as moderately annoying, 1.65 as severely annoying, and 0.5 were unable to lead a normal life due to the severity of tinnitus. Now that's a fairly, if you project those numbers out into the population of the United States, and there's really no reason not to, that's a fairly large number of people who are having their lives severely altered by this condition. And one interesting fact that some studies seem to suggest is that it's not the noise, the sound of the tinnitus that is related to the bother. That is, two people can report tinnitus, which they will name at being roughly the same decibel level, and one will report it as being bothersome, and another will report it as being non-bothersome. Before getting into the weeds on tinnitus, we need to distinguish tinnitus from several other conditions to which it can be connected and sometimes confused. Hyperacusis being one of the more common ones of these. Hyperacusis can be described simply as a physical discomfort or pain when any sound reaches a certain level that would be comfortable to most people. So this is a condition where you're simply more sensitive to sound than the average population. Up to 90% of the people with hyperacusis also have tinnitus, while 40% of the people with tinnitus have hyperacusis. And one other conditions we're going to want to briefly mention, less common, misophonia, literally hatred of sound. It's a condition in which individuals experience intense anger and disgust when they are confronted with sounds made by other human beings. These are usually sounds like chewing, lip smacking, or breathing, and they cause intense anger and physical arousal. And what happens is sufferers usually avoid these situations or endure them with intense discomfort. Now, at this point, you may be wondering, is this a presentation that has to do with behavioral health, or did you somehow click on the wrong presentation? No. We will talk about exactly what this all has to do with behavioral health. So let's start with a number of conditions again that are connected to tinnitus. And as I said, there is some controversy about this. There's evidence on both sides of this question, but there is a body of evidence that suggests that there is a connection between tinnitus and suicide. And I would have to add at a level of personal experience. I've taught mindfulness classes with regular populations and with populations solely from the tinnitus community. I have never had in all of my mindfulness classes in the general population anyone had suicidality as an issue. With the tinnitus population, it's always someone has had in their tinnitus will report having been suicidal at an earlier stage, and not uncommon to have someone at that level in a class I may be teaching, in which case they may not be suitable for that class. So my own personal experience, not that that's a scientific study, but it does lead me to believe that there is a connection there. And there is some evidence, as I said, as you can see, for the connection between tinnitus and suicide. Much less controversial and certainly more clear of a connection is a connection between tinnitus and anxiety and tinnitus and depression. And here you can see some of the evidence. These are overview studies that showed a 45% lifetime prevalence of anxiety disorders and a 33% prevalence of clinical depression. And this has led to there being a general recommendation for tinnitus clients, any tinnitus client, to be screened for both anxiety and depression. And we'll talk about how to do that, or how the connection to that is with a tinnitus client enters your therapy room. And in general, another thing to be concerned about with respect to tinnitus is its impact on the quality of life. There are many conditions that, many issues that tinnitus, by its very nature, just impairs the quality of life. Insomnia being perhaps the greatest one connected to tinnitus. As I said, depression, impaired concentration, impaired understanding of speech, problems with work and family life. It is a significant impact on the quality of life to have tinnitus. Another reason connected to well-being. In a less of a studied mode, that is, there's not a lot of evidence in these next couple conditions, but I will talk about them because this is something I've seen in my work with the tinnitus population, is that trauma is an issue, and that most of those with tinnitus will call the development of the condition, the onset of the condition, as traumatic, and it's not merely a metaphor or an analogy. If you dig down into the trauma criterion, which I'm not going to do here, I will say, I'll talk briefly about one of those, but criteria B through E, intrusion, avoidance of stimuli, negative alterations, moods, and marked alterations in arousal, all of these are to be found in the tinnitus population. And of course, criteria A being the major one, it might not seem at first blush that tinnitus has that sort of serious impact, isn't it, just ringing in the ears? Well, I can tell you, in my own case, when you start hearing sounds out of nowhere, you start thinking, either am I going crazy or do I have a brain tumor? And I was fairly convinced that I was facing mortality as a result of my condition. I spent a lot of time severely anxious about the possibility of a brain tumor or something along those lines. So I would suggest there is a reason to look at tinnitus as trauma. If we just look at, say, as I said, criteria D, negative alterations in conditions, in cognitions, and mood, I don't know anyone in the tinnitus community who hasn't reported all of these conditions. Negative beliefs about oneself, distorted cognitions about the cause. There are all sorts of ways that the tinnitus population blames itself in ways that are completely unrealistic about how they develop their tinnitus. Negative emotional states, diminished interest in significant activities, high percentage with respect to this. Feelings of detachment or strangeness from others, again, very high on this issue. Inability to experience positive emotions. This is like a laundry list of what it is to have tinnitus. So it's something to keep in mind when looking at a tinnitus client. A final mental health condition I will bring up because I think it's vitally important and almost always overlooked is grief. There's not anyone in the tinnitus community that I have met who is not feeling grief, who is not going through grief. And it's almost completely unacknowledged and unrecognized. But there are multiple losses the tinnitus client is mourning. Loss of silence. In my own case, I can't tell you. To never have silence the rest of your life. What it's like to deal with that loss. Many others will speak of the loss of the self that could just go anywhere and do anything, and now they have to be on the lookout for, will this noise, will this crowd, will this bar, will this restaurant overwhelm me? Will I be able to sit through a meal with somebody? And not to have that freedom is, again, a loss of a self. We'll talk later about sort of what to do, but you do basic exploring of the stages of grief with respect to this condition, including what David Kessler called the 6th stage of grief in terms of finding meaning. So these are all ways that tinnitus is clearly an issue for the mental health community to deal with. And what is even more, I want to say encouraging, except you'll see why I would probably want to avoid that, where is that tinnitus has been shown to be associated with depression and anxiety, and the only, and I talked about several other things that I would say it's associated with. And the only established approach to treat tinnitus, not just the only established mental health approach, the only approach to treat this physical condition is cognitive behavioral therapy. And I should amend that a little bit in that there have been several other therapies, and we'll talk about them, that have been demonstrated to be useful with respect to reducing the distress of tinnitus. As we'll see, nothing can reduce the noise of the tinnitus that the patient is feeling, but experiencing. But mindfulness training and acceptance and commitment therapy has also had demonstrable effects on what we call tinnitus distress. But cognitive behavior therapy has been the one that has been most tested and the one that has been demonstrated to be very effective in reducing tinnitus distress. Again, I can't emphasize, it's not that just it's effective, it's the only strategy we have that's effective. That's everything, mental, physical therapies. So this would seem to be a great thing, right? We have this wonderful therapy and this condition that really needs it. So this should be a success story. A suffering population and a group of healers with the not the answer, not the solution, but with something that can assist and aid the people who have this condition. Should be great news. But as we'll see, it's really not a success story. It's really a tragedy. And I don't know any other word that defines what the situation is. And when you look at it, it's bizarre. I don't know any other way to put it. We have this very effective treatment for tinnitus, CBT. Mindfulness, also ACT, that's pretty good as well. But actually, very few audiologists or ear doctors will recommend CBT or any mental health therapy. And in fact, very few tinnitus patients go to therapy. The number is under 1%, far under 1%. And to top it all off, almost no therapists, I admit, very few therapists know much about tinnitus, much less are trained to work with tinnitus clients. So rather than being a success story, as I said, it ends up being a tragedy, almost like star-crossed lovers, the tinnitus clients and the tinnitus therapists, doomed never to get together. So I hope in this talk we can kind of start to remedy that and look at what we can do to change this situation. As I said, what's the failure here? Everyone has not blame in the sense of you've done wrong, but blame in a causal sense of why is this not getting treated? As I said, the ENTs, ear doctors don't recommend. Tinnitus clients don't go to therapy, and therapists just don't have the knowledge that would be useful, necessary in order to treat tinnitus clients. As we'll see, it's not just CBT in general. A working knowledge of CBT is not enough to be an effective therapist for a tinnitus client. So let's talk about this first piece of the puzzle, tinnitus clients not going to therapy. And in a study, very non-scientific study of a very small sample size, because I would sent this out to members of tinnitus groups tinnitus support groups that I have spoken at, in terms of who doesn't go to therapy, who does, and these groups are also actually very high percentage of people in these support groups, and I'll talk about them later, go to therapy. So it's not the best control group, not the best study group, but in terms of why members of this group didn't go to therapy. So we can see there's a great deal of mistrust among this group in terms of why they didn't go to therapy, and that they just don't think they would be understand. A therapist would understand their tinnitus. It's somewhat like a number of people with substance use who don't think that you can treat them unless you yourself are an alcoholic. Even at 20% who couldn't find a therapist who worked with tinnitus, it's not like they couldn't find someone who knew CBT. You could drop throw an axe and you can't help. You open up, as I say, you can open up any page of Psychology Today, and you look at the first 9 people, and 9 of them will list, and first 9 therapists, 9 of them will list CBT as their as something that they're work in, but it's just that they don't list tinnitus, and these people would ask, do you do tinnitus? And the therapist would say, tin a what? And that would be pretty much the end of the story. So I say we start off with a great mistrust from the tinnitus population who don't feel they can be understood by a member, a therapist who does not, him or herself, have tinnitus. So let me go back and talk about briefly what happens in therapy very often for people who do go to therapy. And this comes from my experience in going to probably over a dozen tinnitus support groups, as well as teaching a tinnitus mindfulness groups for a year. And this is a very typical scenario. The tinnitus client who does go into therapy because perhaps the therapist said he knows something or she knows something about CBT, and usually, or it may be the case that the tinnitus client informs the therapist that CBT works for tinnitus, and can you do CBT with me? And then the therapist who doesn't have a knowledge of CBT doesn't have a knowledge of tinnitus, attempts to apply what they know of CBT to tinnitus, and often the results are not very favorable, not surprisingly. And this is shown, again, a small sample study, admittedly, but it mirrors my experience in meeting with groups and meeting with people, and that he said over half of those who went to therapy found it positive but not especially helpful, whereas 8% found it neither positive nor negative. So 1 in 3 roughly finding it positive and helpful, which I think we can do better, get better numbers than that, and I think it's because tinnitus is not something that is well treated with just a sort of generic CBT, just like I'll use the analogy later on, just like we use CBT with trauma, but not just any CBT. Cognitive processing therapy is generally a very effective form of CBT, but it's specifically directed to those who know about trauma. Just so we're going to see it's better when there is a form of CBT that is specifically directed toward the condition. So let's start to talk about then what mental health therapies, what mental health treatments are successful with tinnitus, and what forms of these therapies are successful. And as I said, CBT is the most studied and the one that has the most evidence base for working with reducing tinnitus distress. And again, emphasizing nothing can reduce the sound of the tinnitus. It's reducing the distress of the client who has tinnitus. And there's been many review studies, and they universally have shown that CBT is an effective therapy for tinnitus. Although, as I said, only face-to-face CBT was shown to make statistically significant improvements, which I would expect in terms of CBT, that online or reading books about CBT would be less effective than going to see a therapist with CBT. And so what I'm going to look at in particular is a treatment that we can almost call a manualized therapy from a work that was published just last year that is and provides a wonderful roadmap for how to treat tinnitus. I'm going to go through that as the sort of the guiding light for how to work with tinnitus. And it's a book. It's out of European researchers, both audiologists and therapists coming together, because there's much more research in Europe than in America about tinnitus. And this is CBT for tinnitus, a manualized therapy. 4 co-authors. I'll talk about this particular form of CBT, how these authors have manualized the therapy to apply to tinnitus. And so they, as you'll see, this is not your standard approach. This is not taking the traditional elements of CBT, but there's some elements that are not exactly CBT, but are thrown together in this intervention, in this manualized intervention. So this is all from the book, providing information, functional analysis in terms of medical factors, use of environmentally sound enrichment, again, not your typical, generally not a part of CBT treatment, sound enrichment, applied relaxation, not associated with CBT, cognitive restructuring, well, there we're getting more into CBT type treatments, emotional reactions, how to deal with negative emotional reactions, how to deal with avoidance behaviors, in particular problems with concentration and sleep problems. So these are the components of this treatment intervention. And what they have presented is an 8-week program that I'm not going to go through it in any detail. I'm going to go over the parts in red which are perhaps unfamiliar to those who are working with CBT. We all know things like imagery, deep breathing, relaxation, even if we don't work with CBT. And thought patterns are very standard CBT thought patterns, but I'll work with some of the elements in this program that are unique to tinnitus, and why I think it's very important to use in a CBT approach that is focused largely on tinnitus and grows out of the experience of tinnitus. So one of the, if you saw on that list, one of the elements, components of the treatment is what's called changing views. And this is really an attempt to weaken the link between hearing tinnitus and negative feelings. So the traditional feeling is you get this sound, which can be, again, in my case, a million crickets. It can be pins and needles. It can be a whistle. It can be a lot of things. And what you try to do is to find another sound that you tell the client to have another sound that they can imagine the tinnitus as being associated with, such as leaves rustling, ocean waves, birds chirping, or in my case, crickets. Then you give that sound a context, a positive context. It's not just birds, it's birds in a forest, waves on a beach, crickets on a camping trip. And then you set that association in place, and you have them lower the volume in their mind of the alternative sound. Imagine them moving away from the sound. Have them imagine them moving away from that sound and becoming less and less irritating. So that is one of the pieces of this treatment program. Sound enrichment. This is something that's often done by audiologists, but it's part of this program, which is also a program that has been designed for audiologists, but it's certainly as well something that therapists can do, learn pretty easily to work with sound. All you need to do is to get your client to work with sounds that can help them deal with the tinnitus. That is, and this becomes an important part of working with tinnitus. You really don't want to mask the sound of the tinnitus, because you ultimately want to get habituation to the tinnitus. But you want to have something else besides the tinnitus for them to focus on. And this is important to know when you're working with meditation. You might want to work on meditation. And one thing you don't want to do is have the client sit by themselves with the tinnitus sound and try to meditate. It's a recipe for disaster. All right, you want some sound in the background. This is where, again, knowing about sound therapy is an important piece of working with a tinnitus client. So they can work with different background sounds, and you can have them try them out, for example, when they're meditating or when they're just in everyday mode. Shifting focus is an interesting exercise. It has I think of some similarities to Peter Levine's pendulation, and that is you shift focus from the tinnitus to something else. So you get your client focusing on, first between two things that they, maybe see or feel or hear, going back and forth, shifting back and forth between objects, and then you have them shifting back and forth between the tinnitus and the other sound or picture or whatever it be, and then have them work with this as when the tinnitus becomes troubling. Improving focus, again, in a very important skill for tinnitus clients to work with, to learn their exercises that you can give your client to work with on a regular basis while he or she is doing their therapy with you. And even though, as we meld into the classic CBT component of this treatment, what's important is to understand that there are going to be, you're dealing with a very limited number of situations when you're dealing with the tinnitus client. That is, there's going to be a few types of situations that most tinnitus clients are going to experience and that you need to get familiar with. For example, the notion of a spike. Almost all tinnitus clients deals with spikes, time that the tinnitus seems out of control. And most likely, the situation, the thought's going to be something like, my tinnitus will never return to a normal level. You need to know this is what's going on in the mind of the tinnitus client. Very often, tinnitus clients just think, I can't go on like this, I'll go crazy. They almost always, there's very often trouble with sleep. So rather than just, having to try to quiz your clients and, pull out the thoughts that they might be troubling, it's really if you're asking them what sort of thoughts are you having, you come off as someone who just doesn't understand it. They're going to say, well, what kind of thoughts do you think I'm having? You should know these things. And really, you should know these things because it's not that hard. And there's a very small list of tinnitus situations that are going to be troublesome to the tinnitus clients, and we can familiarize ourselves with those ahead of time to understand the experience of the tinnitus client. The same thing when we're talking about challenging thoughts. We kind of know how to work with these clients when they say my tinnitus will not return to a normal level. One thing you can be certain of is that it usually has returned to the normal level. When the client is reporting a spike, they've probably had dozens of spikes, if not hundreds of spikes before, and it's always returned to a normal level. And you can know this is a form of catastrophizing, without having to speculate that, aren't you just assuming the worst case scenario? You can also point to the fact that, haven't you in the past had, in fact, it returned to normal? And it's a shorthand to undermine their catastrophizing, not in terms of some hypothetical, but in terms of, this is a reality with tinnitus clients. It returns to normal. The same thing with, a good night's sleep, a form of catastrophizing. And it's also the case that, most clients will not have tried much in terms of dealing with the sleep, and it's going to be part of your knowledge base to have suggestions, very specific suggestions for the tinnitus client with respect to sleep, for example. You need to familiarize yourself not just with sleep hygiene, but with what works in the case of tinnitus, and a very important thing to know about. These are just some ways, and I won't go over these, that the authors suggest on how to challenge your thought. And these are more, universal to CBT, so I'm not going to scan those. So that's a very excellent manualized CBT treatment that I think can and should form the basis for the treatment of a client with tinnitus. And I'll come back more to that later on. But I want to talk also about a couple of other therapeutic interventions that can be useful in working with tinnitus. And one of the most exciting ones, and one that I really work with more than any other modality, is mindfulness. There's been not as much research done as with respect to CBT, but a growing body of research that suggests that mindfulness training, and here I mean not just telling your client to be mindful, but mindfulness-based stress reduction, MBSR, the 8-week MBSR program, has been shown to be very effective in reducing tinnitus distress. As this review study showed, 6 of the 7 studies that use mindfulness showed a statistically significant decrease in tinnitus distress scores directly after mindfulness training. And again, it's not just, why don't you be mindful? It's the 8-week John Kabat-Zinn mindfulness-based stress reduction program that brings about the results. And this is what I teach, actually. It's an 8-week online course for tinnitus people in mindfulness-based stress reduction. So it's all of the studies that showed an effective MBSR as an effective intervention work with some version of mindfulness-based stress reduction. The mindfulness-based cognitive therapy, or a woman named Jennifer Gans has a very specific mindfulness-based tinnitus therapy or something like that. So mindfulness is a strategy to integrate, I think, into your treatment. I want to talk a little bit about how mindfulness works and why it works, so you can understand the role or how you might integrate it. So in order to kind of realize this, we got to talk about how mindfulness works as a stress reduction tool Mindfulness-based stress reduction, developed as a mindfulness tool, and it's as a stress reduction tool, and it's tremendously successful. Judson Brewer gives the number of comparing MBSR training to anti-anxiety pills. He puts the number of 1 to 6 in terms of anti-anxiety pills. Benzodiazepines is you need to treat 6 clients to have one successful treatment, and with mindfulness training, it's 1 to 1.5. But let's look at how MBSR works with respect to tinnitus. With respect to stress in general, because that's really how it works with tinnitus. And what mindfulness training is based on is an attempt to undercut the fight or flight response. Right? So, body perceives a threat, sees a bear in the woods, and we go into much beloved fight or flight, activating the sympathetic nervous system with a series of very traditional results of breath increasing, heart rate increasing, all of the standard symptoms for fight or flight. What happens when we don't? What happens when we don't break that symptom, don't break that cycle, is we go into fight or flight, we get stressed. Ideally, we would have the parasympathetic nervous system come online. Of course, in our modern society, that often doesn't happen. It usually doesn't happen. We don't, hit the rest and digest button. Instead, we just get more and more stress. We often invoke really bad coping strategies in terms of maybe substance use, maybe Netflix binging, overeating, overworking, overexercising, that just antagonize the fight or flight response. It doesn't reduce it until there is very often a breakdown and a number of stress-related diseases come into play. Mindfulness then is designed as a strategy to bring awareness to the fight or flight as it arises in the body. And the whole point of mindfulness training is to notice stress arising, take a breath, become aware of it, and recognize it's a choice to go into fight or flight or not. Develop alternate coping strategies that will allow the body to relax, that bring that rest and digest part, the parasympathetic nervous system, onto line. So that's in general how mindfulness works in breaking up the sympathetic nervous system fight or flight response, inducing parasympathetic relaxation. So understanding that helps us understand how mindfulness works why mindfulness works with respect to tinnitus and how it works. So we can think of tinnitus, the noise of tinnitus, as another stressor. It's red flashing light to the amygdala. If you hear walk into a room and your sound is a million crickets, body's going to react in a very stressful way. And this is what happens when clients work with their tinnitus, is they develop, they see it as a threat. The amygdala perceives it as a threat. And going into fight or flight, you go into fight or flight, and you start going bad places in the mind. You start thinking, this is awful, I'm never going to get out of this. You continue to perceive it as a threat, and you never get out of this cycle of perceiving the tinnitus as a threat. And hence, if you're still perceiving it as a threat, you're never going to habituate with it, which is what the goal is for the tinnitus client. So instead, what happens, how we break the cycle of tinnitus with mindfulness, is we bring awareness of the body going into fight or flight. We notice the tinnitus, and we develop the ability to respond in a non-judgmental, non-reactive way. Mindfulness helps us respond in general to external triggers in a non-reactive way. And mindfulness training helps us respond specifically to the trigger of tinnitus in a non-reactive way. And it's this non-reactive judgment towards our tinnitus that is the key to habituation, to no longer being triggered by the tinnitus. If through mindfulness we can sit with it and not perceiving as a threat, the sense that we have to go into fight or flight is broken, we can sit with the tinnitus in a relaxed manner, and this is the goal of habituation. This is when tinnitus loses its impact on us. The tinnitus itself doesn't change, but our reaction to it changes. And this is how mindfulness training works. And again, it's not just telling the client to be mindful, it's training the client in mindfulness-based stress reduction so they can no longer react in this fight or flight manner with respect to their tinnitus. Now, it's not easy, it's not quick. The 8-week MBS core is a good start. And that's why, as I said, the research have shown this course has gotten very good results in terms of getting people to work with their tinnitus and lose their tinnitus distress. So just to review how mindfulness works, and then we'll compare the two. Mindfulness, we know, as MBS training, uses meditation, and we know meditation reduces stress. And one thing that tinnitus clients need is stress reduction in general. So there's a component of just the meditation itself is helpful, and that's why you see in the CBT component, CBT training, that uses a lot of relaxation meditation techniques. Mindfulness also increases the ability to focus on non-tinnitus related elements of the present, and this is what the tinnitus client really needs to do. Is tinnitus is always going to be there, but if they can focus on something besides the tinnitus, they'll notice it. And every tinnitus client will actually be able to tell you times when they were so absorbed in something that tinnitus went away. It just wasn't there. And that's what we need to do. That's what working with mindfulness can do, is increase that focus on non-tinnitus elements of the present moment. But the main certainly result of mindfulness training is to train the body to respond in a non-reactive, non-judgmental way to external triggers in general. That's what MBSR does. Hence, that's how it's a stress reduction tool. And as we respond to external triggers in a non-reactive way, we learn to respond to our tinnitus in a non-reactive way as well. And that non-reactive attitude is what is the key to habituation that the tinnitus clients are after. And in general, mindfulness, MBSR is a great stress reduction tool. And again, every tinnitus client will tell you that when their stress goes up, their tinnitus gets worse. And when they have this tool, it is something that is not just for the tinnitus specifically, but for their life in general. That's why I think every mindfulness training is a great thing, and I recommend every tinnitus client engage in an MBSR class. Just for a moment, I'd like to contrast CBT and mindfulness. We can say one way I like to look at it is CBT is a top-down strategy. It aims at changing our way of thinking about our tinnitus. So we change all these bad thought patterns about tinnitus, like, oh, this tinnitus will destroy my life, I'll never live a normal life, I can never sleep again. All of these negative thoughts you can deal with CBT, classic CBT, by changing our thought. But mindfulness works at changing the way our body responds to the sound of tinnitus. And I like to compare this. An analogy I use is, imagine that you wake up and your smoke alarm's blaring, and you jump out of bed in the middle of the night, and your body's in fight or flight. You're running around looking, where's the fire? Where's the fire? Can I grab stuff to get out of the house? And after running around and noticing there's no fire, and you realize the smoke alarm is broken, and you tell yourself the smoke alarm's broken, use your reason, and your body will begin to calm down. Right? It takes a while to get out of fight or flight, but your reason can ultimately calm the body down. But now try going to bed and leaving the smoke alarm going and see if you're going to sleep. No matter what story you tell yourself, the telling yourself is not going to help you get to sleep when that smoke alarm is blaring, right? CBT is like telling yourself there is no fire when that smoke alarm is going. And mindfulness training is learning to work in a different way with the noise, training the body. It's a bottom-up sort of experience. And I think actually, although there is a place where there can be conflict, these are actually very complementary tools to use in treating a tinnitus patient. So those will be, the main tools. A couple. And these are ways to get mindfulness training, as that every tinnitus client should do an 8-week MBSR course, should have that knowledge. I mean, every human being probably should do an 8-week MBSR course. I teach an 8-week course just with tinnitus clients. Jennifer Gans, who is a wonderful, wonderful psychologist who has developed what's known as mindfulness-based tinnitus stress reduction, an 8-week course. It's a do-it-yourself course for $225, but you have to do it yourself. My course is live online. Clients working with each other and working with me. They could take a basic MBSR course online or in person. They run about $600, but it's the best $600 they will ever spend. There's also a free version of the MBSR course. One of the best, most amazing things on the internet. 8-week course called Palouse Mindfulness. Completely free, has all the material for the class, all the exercises, wonderful videos, links. It's just a work of love, this class is, and it's a great place to start. The only drawback I would say is it's very hard to teach yourself to mindfulness. I think a good teacher is truly important, but it's a starting point for people who maybe are suspicious about mindfulness. So I want to go over a couple other therapies and explain them that can be useful in working with tinnitus clients. There has been not a lot of research on acceptance and commitment therapy, although the research that has been done is, in fact, very promising. A couple of studies in 2011 and 2012 showed a large percentage of participants had clinical significant statistics for decreasing tinnitus distress. And some it even beat a very common, in the second study, it beat a very common tinnitus retraining therapy at reducing tinnitus distress. Now, acceptance and commitment therapy, there's basically two components, right? Mindfulness and really value theory. I always like to describe acceptance and commitment therapy as if John Kabat-Zinn and Viktor Frankl had a kid, that kid would be acceptance and commitment therapy. It's important to understand both of these components play a role in working with tinnitus. It's easier to see the acceptance or mindfulness component of acceptance and commitment therapy. This is a video. If you go online, you can find the unwanted party guests. Is a good illustration of the acceptance part of acceptance and commitment therapy. The example is, imagine you throw a party for all your friends, great party, you got everything planned, people are showing up, everyone's having a good time, and all of a sudden this unwanted guest Dave arrives and he starts to wreak havoc on the party. You throw him out, but he keeps coming back, and you got to stand by the door, and that's the only way you can guarantee he doesn't get back in, because he's a sneaky fellow. But you notice when you're standing by the door, you're not enjoying the party. So you say, what the heck, let Dave in. And what, again, acceptance and commitment therapy says happens is when you let Dave in, you can still have a good time with Dave there. And you notice that when you stop trying to get rid of it, right, Dave calms down. And so this is classic acceptance and commitment therapy on working with psychological discomfort. It's just you can still live your life with the discomfort being there. And when you stop trying to get rid of it, it kind of reduces itself. This is a good analogy of working with tinnitus, because the tinnitus client doesn't think that they can live with, have a life with tinnitus there, but it's like Dave, they can. And I think that element of is important to show them as well. The fact that when you stop trying to get rid of the tinnitus, you accept it, then you can begin to habituate to it and not react to it in the way that's causing you distress. And this is the acceptance component of acceptance commitment therapy. And I think it's, part of working with a tinnitus client is working on that acceptance. But what's equally important is the commitment aspect, the value aspect of acceptance and commitment therapy. And here, if you've noted, there's a video on YouTube you can find called 3 Happiness Myths that one of the founders of acceptance and commitment therapy uses to explain what what ACT is compared to the common conception of happiness. And that is the myths are most people think happiness is a natural state. We should all be happy. It's just equivalent to just feeling good, and that if you're not happy, you're defective. Those are the 3 happiness myths. And what ACT tries to show us is that real happiness is not inconsistent with emotional distress. And in fact, it comes from things like our relationships, our friendships, our family, our community, our spirituality, our career. If we focus on these things, we can have a meaningful life regardless of the level of psychological distress we're having. And this is very important to point out to the tinnitus client, because they get so wrapped up in the daily distress that they forget of all these other goals they have in their life that they can focus on instead of focusing on the tinnitus. So this method, I say, becomes, I think, an important piece of treating tinnitus. A couple more therapies, interventions I'll throw out that I have found useful, although there's not a research base for them. But I found polyvagal informed work really helpful, and that is what you're working with the tinnitus client at doing is getting out of either the fight or flight mode or the shutdown dorsal vagal mode. And that what polyvagal informed theory gives us is a variety of ways to get out of these alternate states and into the ventral vagal state. So here is the typical classic ladder for the polyvagal theory. At the top you have this ventral vagal state of connection, which is where we all like to be. Everything's peace, the world's a good place. We have this parasympathetic fight or flight zone where we're anxious, stressed, or if that fails, fight or flight fails, we break down in this dorsal vagal shutdown collapse state. Tinnitus clients very much know fight or flight, and they will also identify readily with the shutdown that comes when they just can't seem to escape their tinnitus. What helps is to let them know that we can manipulate our nervous system in ways that can be useful. And I think especially they find, and you can convince them of this polyvagal mantra, that story follows state, why it's important to get out of fight or flight or dorsal, get into ventral vagal, is because when you're in that connected state, you view your tinnitus differently than when you're in fight or flight or when you're in dorsal shutdown. So developing and then the ability to have a flexible nervous system to work with mechanisms for getting out of fight or flight or out of dorsal vagal. Breathing exercises, I think, being one of the most important pieces to bring to this case. And I'm a big fan of James Nestor's book, Breath, the New Science of a Lost Art. But also what's, I think, useful, separate interventions, but very much in a polyvagal mode, and that is positive psychology exercises. And this was a recent tinnitus today that had a very specific articles on positive psychology, because this is something that can be used to bring the tinnitus client into this, state of a ventral vagal connection. Exercises such as the gratitude journal, all walk, giving, doing kind things to 5 kind acts in a day, and all of these exercises that you can get them to work on to increase this ventral vagal state of connection. And finally, even simple DBT exercises to work with, especially distress tolerance skills, and simple skills that might help them get out of fight or flight or out of dorsal, can be very useful in getting the tinnitus client to work with their nervous system. So I think all of these can be useful. And that, sort of as an overview, I'd say CBT is far and away has the most evidence base for reducing tinnitus distress, but it needs to be addressed to the tinnitus client's specific needs. A generic CBT is better than no CBT, but a CBT that is grounded in the knowledge of tinnitus and the needs of the tinnitus client is far more effective. And I think that the Buick's book that I went through serves as an excellent basis. Mindfulness should be part of working, not just mindfulness in general, but MBSR training and some pieces of acceptance and commitment therapy. As well, as we said, polyvagal, positive psychology, and DBT can also be used to help the client manipulate the nervous system to extricate themselves from fight or flight or this dorsal vagal shutdown. So those are an overview of the therapeutic approaches to tinnitus. And this last piece I want to talk about is how to work with just some specific directions, suggestions of what to do when a tinnitus client walks into your office. We'll start with an understanding of probably what has gone on before that client has walked into your office. Probably 9 out of 10 times this is a story that they've been told by their audiologist or ENT that there's nothing to be done. I mean, it's not unusual. I hear this all the time at the tinnitus support groups I visit is, the ENT told them, go buy a fan. That's the extent of what you can do. They've literally been told that's it, end of game. On the other hand, the internet has more scams than you would think are possible that are telling people they can cure their tinnitus. So they have this, science, man of medicine telling them nothing can be done. The internet promising all wild cures. And for some reason, they've read that CBT can be useful, although, as I said, they're very skeptical. How can working with my thoughts help this physical condition? So they're going to walk into your office skeptical. And unfortunately, the first thing you have to tell them is something they probably already know, but it needs to be pounded home, and that there is nothing that you can do and nothing that anybody can do that is going to reduce the noise of their tinnitus. This is a statement I read to all my clients from the National Center for Rehabilitative and Auditory Research. Many people with bothersome tinnitus spend a lot of time and energy searching for a way to quiet or eliminate the tinnitus. Unfortunately, there is currently no therapy that can safely and consistently reduce the loudness of tinnitus. Right? So I, as therapist, am not going to be able to reduce your tinnitus. That said, I want you to know that there is a lot I can do for you. And so I've developed a sort of ABCs of tinnitus treatment. This is mine. I don't know how good they are. I'll probably modify this tomorrow, but for now, the first way to work with the tinnitus client is to begin by acknowledging the mistrust. The tinnitus client is going to be very suspicious of how this therapy is going to help them with this crazy noise that's in their head. It doesn't seem to make any sense. So you're not going to reduce the noise. What good are you? But they're really doing this, for some reason, the story of Kafka in the trial comes to mind, the story of the guy who goes to the castle, and he's not allowed in the castle, and the guy who's guarding the door of the castle tells him he can't get in, and the guy who wants to get in gives the guy all his money, and the guard says, well, I'll take your money, but this is just so you feel you've left nothing undone, but it doesn't do you any good. So it's not crazy to see the tinnitus client is somewhat in that condition. They're going to try. This is something that either the family told them you got to try, or someone told them, and they just want to see, well, I can at least say I left nothing undone. It's our job as therapists, as I said, to reassure them that even though I don't have tinnitus, because most of the people working won't, that I can help you. That a cancer doctor doesn't need to have cancer to treat cancer. I found that analogy very effective. And you also have to know the evidence that, look, we know this CBT can help you, and that and mindfulness can help you, and that these interventions can really increase your quality of life. So you have to be the reassuring presence with the knowledge that can begin to give them hope. As I said, I suggest you do use a manualized intervention rather than just rely on kind of generic CBT, and that the book I talked about, I think, is an excellent starting place. I'd say edit it for example, the part on mindfulness in there is weak. So I think you would want to increase that, and other things you could bring to it, the acceptance and commitment therapy piece, and these other pieces I think can supplement it. In addition to the therapeutic resources, you want to familiarize yourself with also other interventions and resources for the tinnitus client, and I'll talk about some of those in a second. So when that tinnitus client walks into your office, you're going to want to do some assessments. And this is can be problematic because there's a number of tinnitus assessments out there. I mean, you want evidence. Here's your starting place. Here's where you end up after the treatment to show that they've improved. These are 5 fairly standard ones. They all have arguments on their behalf: the Tinnitus Handicap Inventory, Tinnitus Reaction Questionnaire, Tinnitus Functional Index, Tinnitus Handicap Questionnaire, Tinnitus Primary Functions Questionnaire, and there's more. I like the Tinnitus Functional Index, and you can look that over. These are some of the questions. It allows you to rank the client to rank their performance in a number of areas from 1 to 10. It gives you a lot of information as a baseline. A lot of places demonstrate improvement, but you really need to look at all of these scales and think of how are you going to assess your tinnitus, your success of working with the tinnitus client. There's some basic recommended screenings from a therapeutic point of view: the GAD-7, PHQ-9, the Columbia Suicide Severity Rating Scale. All should be done as an initial assessment. You want to be able to distinguish between approaches that target the client's reaction to the tinnitus versus approaches that target the percept itself. So all of our therapeutic interventions work with the client's reactions: MBSR, ECT, ACT, and CBT. But there are other components that you're just going to want to familiarize yourself with, because you want to know what other things the client might be working on, needs to be working on at the same time. And so medical management, sound therapy, hearing devices, and tinnitus retraining therapy I briefly want to touch on. Medical management very rarely, but sometimes there may be a pathology associated with the tinnitus, so the client needs to be medically checked out. Sound therapy, as we talked about, that's something he can be working on with a therapist. You can be working on with an audiologist. There's a lot of good independent resources out there. I'll talk about one of those in a second. You need to know the situation with respect to hearing devices. Sometimes there's hearing loss with respect to tinnitus, and so in some cases, actually, hearing devices can impact the tinnitus, and that's something clients need to, again, work with an audiologist or ENT. There's something that I'm not going to go into here except to outline it, called tinnitus retraining therapy. That is a very extensive as well as an expensive 12 to 24 month training where you wear devices, you generate sounds that you're working with in a much more extensive way, developing habituation that goes well beyond traditional therapy. And that's not something you're going to be dealing with at all, but it is something your client might ask you about, and you need to know a little bit about tinnitus retraining therapy. More on a hopeful or a note of something that is doable is what's called progressive tinnitus management. And this is really the VA works with tinnitus at 5 levels. And the benefit of this is that there's some excellent materials in terms of working, especially with sound and some basic other elements that come from a progressive tinnitus management program. There's some CBT material, but the primary stuff is skills education and working with sound that they can get out of a progressive tinnitus management class that is available free and online, and there's some literature as well that's free and online. Other resources that the tinnitus client needs to know about is, first and foremost, the American Tinnitus Association, which is the primary advocacy group for tinnitus. It's a wonderful organization. The website's amazing. There is a magazine associated with the organization called Tinnitus Today. These are resources the client needs to know about. Excellent resources on that website. Tinnitus support groups. There are a variety of, there used to be only in person, and one of the upsides of the pandemic is a lot of support groups went online, became much more popular. So the clients can find tinnitus support groups online, and these are listed on the ATA website as well as on in the magazine. There is, as I said, a free progressive tinnitus management training put out by the VA that clients can access. Gives a lot of great information as well as especially some good work with sound. And as we're getting toward the end here, this is from probably one of the primary researchers on tinnitus, James Henry from the VA. Heard him give a talk recently in which he was pretty blunt. I think this is important to keep in mind. Standards for tinnitus care do not exist either within or between the different healthcare disciplines that offer tinnitus. So there are just, everyone's in their own little area, and even in each community, people aren't talking to each other. And to top it all off, outside of the VA has some excellent resources, but access to evidence-based tinnitus evidence-based services is very limited. And as a close, what I think needs to be done in the community, in the therapeutic community, is the following. We need to adopt a standard manualized therapy. And again, I think the CBT book that I've talked about is an excellent starting place. Once we have that therapy and treatment, we need training and certification of therapists in that intervention, so people can be shown to be able to give the intervention, and that clients can there's a database where clients can look up, who has this sort of training in my community, in my state, so I know who has knows this tinnitus treatment, and I can go to them. And if we do that in the therapeutic community, we can go a long way toward decreasing the distrust and toward bringing the healing that is ours to bring to this community. And that's the really hope here that I think we all need to latch on to and work towards. So thank you for listening to this. I hope you found it helpful.